So, first of all, let's begin with this statement. Pseudoscience and quackery are everywhere, mostly on the online for sure, and with just a 5 minutes Google search saying I did exactly the same thing Dad did for a talk. And you can find a very easily weird explanation explaining that tinnitus is due to vibrating swollen nerves. You can find ear ringing treated by lipoflavonoids, which are considered by ENTs as the most efficient and effective over-the-counter solution by lipoflavonoids. You can also find ointments, you can find ear drops, you can find massages, you can find acupuncture and herb to quiet tinnitus. You can find chiropractic care to treat tinnitus. You can find acupressure points. You can find Ayurvedic medicine for treating tinnitus. You can find Tibetan singing bowls to treat tinnitus. You can even find a bunch of videos explaining how easy it is to get rid of the tinnitus. And indeed, there is an endless list of therapies that are proposed, claiming that they are efficient to treat tinnitus. And the question is why? Why it is possible that so many strange, weird, pseudoscientific quackery and other scam medicine may emerge on the web and elsewhere? This is a real question. In my opinion, there are at least 4 explanations that can be given. The first one, the fact that there is no cure for tinnitus. And indeed, that has shown that both CBT and sound therapy, masking, or even hearing aids have been proven to be efficient, but not to silence the tinnitus, just to help the patients to deal a little bit better with his or her symptom. This is exactly the same thing for vasoactive drugs, also for anticonvulsants, for antidepressants, and for the variety of neuromodulation techniques that have been proposed for tinnitus treatment, including TDCS, RTMS, or other electrical or magnetic stimulations of the brain. The second explanation is the fact that it is probably a patient's concern, because the patient doesn't find in the Western medicine therapeutic proposals a solution to his question. I want to get rid of the tinnitus. And if we look at a corpus of more than 100,000 posts about tinnitus extracted from the Reddit software, and if you subject this post to unsupervised cluster analysis, you may be able to identify main topics that are interesting for the patients in their freely available online discussions. And 2 clusters are of specific interest in this context. The first one is the cluster Hope for a Cure, this one, with words such as cure, lifetime, God, future, someday, pray, hope, treatment, awareness. And the second one is the dietary supplements and alternative therapies that accounts for 3.2% of all the text and all the posts, with words like supplement, vitamin, magnesium, CBD, zinc, oil, biloba, B12, ototoxic, benzo, withdrawal, and ginkgo. Meaning that for the patients, it's important to try to find out a solution that the Western medicine and the available evidence is not able to propose. And if we look at the data on our population, we see that more than 50% of the patients turn to complementary and alternative medicines by using medical products and practices that are totally out of the medical mainstream. The third explanation is that our judgments and our decisions are biased. This has been demonstrated by Kahneman. He won the Nobel Prize because he has demonstrated with his colleague Amos Tversky that the decisions and judgments made in the economics and in the economical world are all biased by cognitive illusions. Meaning that even if we are told that we are thinking wrong, we persist in our wrong way of thinking. This is true for everybody, including patients, doctors, and other healthcare providers. Here you can see two very important biases that are of specific interest in our context. The first one is the confirmation bias, is the tendency to give credit to information that confirms and reinforces the things that we already think or believe. If I think that a natural therapy is good for me, then any information proving or saying that natural therapies will be efficient in tinnitus will be much more important for me than anyone. And the second is the causality bias. This is the tendency to overestimate the degree of causality between two events, or even believing that two events are causally related, even if they are not, leading to decisions that are biased by this illusory causal relationship. And I want to explain to you that these cognitive illusions are very strong. They act as visual illusions, and they are as strong as visual illusions. This is a very good example. You can see here two squares, square A and square B in this chessboard Adelson illusion. Obviously, you find that square A is darker and B is lighter, but your visual system is tricked. It is tricked by the shadow produced by the green object and by the four dark squares surrounding the square B. If we look at this, the same chessboard a little bit differently, just by adding a connection between square A and square B, you can see that those two squares are exactly the same. If I had to paraphrase a very well-known novel, I would say they have exactly the same shade of gray. Exactly the same, but if you look at them in a specific context, then you see them different. It's impossible not to see square B as different from square A. And this is exactly the same for cognitive illusions. You know it's wrong, but you can't help yourself to think in another way. Can you swear that you will never ever buy, as a client, buy a useless item sold for $90, euros or pounds, whatever, and a currency will work exactly the same? If you are a patient, thinks this guy explained online that this treatment worked for him, it's worth a try for me. Or if you're a doctor or any healthcare provider, think a phrase like this: my patient is doing better thanks to the very efficient treatment I gave in the last consultation. All those statements are false, are biased, and it's very difficult. You need to engage a very, very costful cognitive effort to put these statements away from your mind and think in a right way and not in a wrong way. And the fourth explanation is the importance of the placebo effect in the field of tinnitus. The placebo effect is a beneficial effect produced by a drug or a treatment which cannot be attributed to the placebo itself. I want to remind you that even if it's not supported by the drug or the treatment, the placebo effect is for real. It is very frequent in more than 50% of the patients in some conditions. It involves the dopaminergic system, the immune system, the endorphins. It is measurable in terms of brain activity. It may last months, induce negative outcomes, the so-called nocebo effect, and even an addiction. You may be addicted to a drug, a pill, a treatment that has no efficiency by itself. It may depend on the color of the pill, the cost of the pill, the time spent during the procedure, the patient and the therapist believes. And it can be transferred, for example, from therapist believes. Even if it's not supported by the treatment itself, the placebo effect is for real. And the placebo effect is key in tinnitus and hearing disorders. Just let me show you that using three different examples. The first one, the first example is a study conducted in 1984 to investigate the contributions of the placebo effect in clinical tinnitus studies. And 20 patients who responded to a lidocaine injection in the first phase of the study were contacted, and instead of injecting the efficient treatment, the lidocaine, the authors injected 5 centimeters cubes of placebo saline solution. And 40% of the patients described as change in their tinnitus following the placebo injection because they thought that there was a real treatment that was injected. Same thing for hearing aids. The second study is a study where the patients were proposed either a brand new hearing aid or an old one. In fact, the two hearing aids were exactly the same, and they were fitted with exactly the same fitting. And a significant proportion of participants, 75%, expressed an overall preference for the new hearing aid, meaning that if you think that the treatment is more efficient, more new, more something, then it will be a better outcome than the control procedure. And it has also been shown that subjects in tinnitus trials improve in tinnitus distress over a short waiting list phase, meaning that intolerance produced by the tinnitus. So to sum up, there is an unmet patient's demand. They want to silence their tinnitus, and the Western medicine is unable to do that. Our judgments and decisions are irrational. Third, there is an important placebo effect in the treatment of tinnitus, and that leaves room for unproven therapies. So, what is the evidence for use of complementary and alternative medicines in the field of tinnitus? To date, almost none. We've recently conducted with Deb a short clinical short review of the literature, of the trials, and the available data of these therapies. And there is a possible effect for acupuncture, but with poor randomized controlled trial quality. No evidence for herbal therapies. Other herbal therapies aimed at treating associated depression or anxiety for those psychological conditions that can be frequently associated with tinnitus. And for Kava, there is no evidence with possible side effects. And for St. John's wort, the herbal therapy has exactly the same efficacy than selective serotonin reuptake inhibitors, but they have also exactly the same side effects and the same interactions with other drugs, meaning that complementary and alternative medicine doesn't mean absence of possible harmful effects. And for zinc, melatonin, homeopathy, and aromatherapy, no evidence and possible side effects with these treatments. If we look at the international guidelines for tinnitus management, indeed, they found no evidence, no recommendation, and even recommendation against the use of acupuncture, dietary supplements, homeopathy, or aromatherapy. To date, there is no indication, at least in the Western medicine, and if we look at the evidence given by the literature, to use these treatments in the field of tinnitus. This leads to another question. Is it ethical and legitimate to propose a placebo therapeutic intervention? The answer is yes. but only under very, very strict conditions. They're summarized here in the paper from Luxembourg in 2004. First, the intentions of the physician must be benevolent, and no economical, no professional, no other thing may interfere with the decision of the healthcare provider. Second, the placebo, when offered, must be given in the spirit of assuaging the patient's suffering and not mollifying him, silencing him, or failing to address him or his or her distress. If proven ineffective, the placebo should be immediately withdrawn, and the placebo cannot be given in place of another medication that the physician reasonably expects to be more effective. If asked about the efficacy of the treatment, the physician should not hesitate to respond honestly what he expects and the reason why he has proposed this treatment. By the way, if the patient is helped by the placebo, discontinuing the placebo in absence of more effective treatment would be unethical. So, prescribing a placebo is not forbidden, but it has to be considered in a multidisciplinary management under medical supervision, and those statements regarding ethics and deontology for use of the placebo as a medical intervention has to be strictly followed and as a conclusion and some take home messages, there's scientific evidence supporting the use of alternative therapies in the field of tinnitus remains poor. If we consider the evidence-based medicine standard. Nonetheless, keeping in mind that there is no curative option aimed at making the tinnitus disappear, non-harmful complementary therapies and their potential placebo effect may be worth consideration in the multidisciplinary management of the tinnitus sufferer. Conversely, one should discourage the use of such unconventional interventions without medical supervision that could let the patient get lost in kind of irrational search for a miraculous cure made of false hopes and costly and unproven and sometimes even detrimental alternative therapies. Thank you for your attention.
Thank you very much. And the floor is now open to questions. We already have a couple of questions. Professor Hall, are you, could you please turn on your, yes.
Hi.
Thank you very much. Thank you to both speakers. Thank you for that very interesting talk, and I have to say very provocative topic and very interesting topic. So one of our questions is, I think it was Professor Hall already answered this in the chat as to please define hearing specialists. So if you're looking for an answer from Professor Hall, you can look in the chat, and she says hearing specialists in the context including ENTs, otolaryngology, audiologists, and hearing therapists. There's a question to both speakers as to how we can address the individual needs of our patients with the standards of evidence-based medicine, example, RCTs, etc. Because tinnitus is very highly heterogeneous, and how can group statistics apply for personalized needs? So either or, anybody can take this question.
So I posted a few thoughts in the chat. So I hand over to Alain, maybe he wants to share some thoughts about heterogeneity and personalized treatment.
I'm not sure we can see your comments in the chat. Are you talking about the group results of the Mentimeter?
No, I put it in the Q&A.
Oh, okay. Okay, then. Oh, yes, I do see that. Can you maybe summarize that for us? I don't think our audience can really, I don't know how many of them saw your answer. So if you can just answer the question, yeah.
Okay. Yeah, so in response to Martin's question, I would say that the sort of study designs that I talked about, yes, they're using group statistics. And so those results tell us that on balance, a majority of patients report improvement. That in itself is still clinically useful because it means that the balance of probability indicates that it is still worth offering that treatment to your patient, because most patients do show some improvement. However, I do agree that not all patients improve with a particular kind of treatment, even CBT that has the kind of greatest level of supporting evidence. I would say as a scientist, from a research perspective, we still don't have a good grasp of heterogeneity in terms of what causes tinnitus, what maintains tinnitus, and what are the factors that might predict patient benefit. But we are making some big efforts in this direction, and a lot of research efforts are being focused on answering this question of heterogeneity. So I don't have an answer now, but hopefully in the future we will know more about that in a way that can guide clinical practice.
Absolutely. That's, yeah, as a researcher, I can totally resonate with that. But hearing from the clinic, Professor Londero, so how do you, there are multiple people on this series who've tried to answer this question as to how they approach they approach patients from a clinical perspective. So how do you take into consideration the heterogeneity? What is your advice to the clinical world?
It's a very difficult question and no straightforward answer. I think that you need to understand a little bit better what are the patient's concerns. This is probably the most important thing during the first consultation. And this is why the questionnaires are useful, because they may help to understand a little bit better what are the domains of interest for the patient, meaning sleep, attention, anxiety, depression, the tinnitus itself. And this is part of my job, to try to put every patient in kind of the most homogeneous box with other patients that are almost the same. No patient is exactly the same when compared to another. But I think that trying to put the patients in kind of homogeneous box may help after to understand a little bit better what can be done and what has to be done to, if we're unable to silence the tinnitus, it's possible in some clinical situations. If I think of autosclerosis, there are some vascular loops in the inner ear canal, or there are solutions that are aimed at silencing the tinnitus. This is exactly the same for a pulsatile tinnitus. When a patient comes to my clinics with a pulsatile tinnitus, I know in about 10 seconds what is the cause and what can be done or not to silence the tinnitus. But in most of the cases, the problem is not to silence the tinnitus, but rather to help the patients to do a little bit better with it. And for that, the more I understand what are the patient's concerns and